Better,
The room is open, ma'am.
it's already open. Okay, okay.
So we are live on YouTube. So we are visible and audible into the attention.
Netra, I think we can start.
Yes, Dr. Ravi.
Okay. So a very good evening to all of you. And uh, today, on behalf of the Indian Academy of Neurology and the Autoimmune subsection of the Indian Academy of Neurology, we all invite you to be a part of this first webinar, which we have planned as different activities of the autoimmune subsection. Today, the webinar is about basics of immunology, and we have targeted on basics of the B and T cells and the behavior for CNS. And this will be followed by the overall understanding of the immunobiology of neuromyelitis optica, spectrum disease, and MOGAD, which are getting more frequently to be seen now and understood better with more better therapeutics. And then it will be followed by the immunobiology of multiple sclerosis, one of the most common conditions among CNS demyelination that we all see. So hopefully this will set a background for us to further understand the different diseases as we will cover them successively on our webinars, which are planned over the next few months. And we will be sharing those details as and when the webinars will be happening, but they're all planned with individual immunological understanding of disorders as well as to cover various disorders. So from here on, I request Dr. Netravati, who's the convener of the autoimmune subsection, to kindly take over and introduce the first speaker.
A very good evening, everyone, and welcome one and all to this inaugural session of IN Autoimmune section. So first, we have a speaker, Dr. Manjunath, who is an associate professor at the Department of Neurovirology at NIMHANS, Bangalore. So basically, I worked with him in few of the flow cytometry studies in multiple sclerosis and aquaporin related disorders. So he runs the flow cytometry lab at neurovirology, and his experience has been in many viral infections and immune mediated disorders. So I welcome you, Dr. Manjunath, for your first session on the T and B cells in immune system.
Thank you very much. Good evening, everyone. I really am grateful to Indian Academy of Neurology, Professor Rohit Bhatia, and my colleague Dr. Netravati for this opportunity to, present my talk here to be part of this fraternity today. Let me share my screen. It's nice. Is it visible? Sorry. Hello?
It's just starting to get shared.
Starting, Manjunath.
Ah.
Maybe you can go back and again log in.
Resume share.
No,
Yes.
it's come now. You
Okay.
can just put it up on the slideshow. Yeah, they are seen. They are well seen.
Yeah, my topic for today is T cells, B cells, and immune behavior in relation to CNS. I have mostly included lab aspects and what has been understood from the animal models, mostly with respect to neuroimmune interactions. My slides are not okay. Right. So these are the contents of my talk today. The immune system basics, lymphatics, and immune surveillance, crosstalk between immune and nervous system, a little bit of introduction on innate cells and role in neuroinflammation, T cells and B cells in neuroinflammation, a bit on lymphatic system, and maybe a bit on target autoantigens and therapeutics. So coming to the basics, you're all familiar. Our immune system is basically divided into innate immunity and adaptive immunity. Here you see all the cells that represent the innate immune system, the granulocytes and the natural killer cell, the macrophage, the dendritic cells. And you have on the right, the adaptive immunity mainly constituted by the T cells and the B cells. So the T cells are again divided into CD4 and CD8 T cells. And here in the interface, you have what you call the gamma delta T cell and the natural killer T cell. And recently you have other two cells called the mucosal associated invariant T cells and the innate lymphoid cells, which have been added to the interface here. These are called the innate T lymphocytes. And I would like to bring your attention to the fact that these innate T cells are gaining more and more attention in autoimmune disorders, including CNS autoimmune disorders. So we'll see the cells in a bit of detail. Coming to the immune privilege of CNS. So for a long time, ever since the Nobel laureate Peter Medawar proposed that CNS is an immunologically privileged site because he found that skin grafts implanted into brain did not survive longer than other places in the body. And later on, all this was explained, due to the blood-brain barrier, the immune privilege is what is available for the CNS, and the transforming growth factor beta, the cytokine, during homeostasis is extremely important for maintaining the blood-brain barrier integrity. And under pathological conditions like infections or autoimmune conditions, the cytokine TNF alpha has been known for a long time now to enhance the blood-brain barrier permeability or cause a breach in the blood-brain barrier as such. So coming to the barriers that are there in the CNS, which are under homeostatic conditions, protective for the central nervous system. The two main barriers, the blood-brain barrier here on the left and the blood CSF barrier on the right. So the blood-brain barrier, especially which its tight junctions in the endothelial cells in the blood vessel, is extremely important for maintaining the integrity and for selective movement of molecules or solutes across the blood-brain barrier, and extremely selective to cells and under normal conditions. And blood CSF barrier, on the other hand, you see the endothelial cells have these fenestrations. So it is more thought of as permeable for pathogens to enter, and even for cellular movement during homeostasis, and even for during inflammation for the cells to get into the CNS easily. And there are certain immunological barriers which are known to protect the brain. So taking three main cells of the central nervous system here, the astrocyte, whenever there's an activated T cell which is expected, which is present in the CNS, through the FAS and the FAS ligand mediated interaction, the astrocyte is known to induce apoptosis of the T cell, thereby killing the T cell by apoptosis. Preserving the preserving the neurons. On the other hand, the neurons secrete, under homeostatic conditions, a lot of TGF beta, which are known to convert the naive T cells more into a protective or a regulatory T cell called the Treg cells, and the microglial cells. Whenever there is presence of a T cell, then so through the B7H1 interactions or the CD80-86 interactions is known to suppress interferon gamma production and increase IL-10 production, which is more immune suppressive or immunoregulatory in nature. And it can also induce apoptosis of this T cell through the IDO pathway, wherein the tryptophan is converted into kynurenine. So these are three immunological barriers. And coming to CNS immune surveillance, it's known that the blood-brain barrier restricts entry to most cells. So there are low frequency of naive T cells present, and the resident cells express low levels of antigen-presenting molecules, the MHC class 1 and class 2. And more importantly, it's well established that there are no regional draining lymph nodes. But antigen from the CNS is known to drain into the deep cervical lymph node and later on to the spleen. So what changed the scenario of the immunological privileged nature of CNS is this remarkable study that came out in 2015 in Nature by Lowell et al., where they showed in this mouse brain, here you see the transverse sinus and the superior sagittal sinus on top of the mouse brain, which is stained with the markers of lymphatic vessels. That was for the first time a formal proof available for presence of lymphatic vessels in the murine brain. And soon after that, it was it was also established that through autopsy studies that human brains too has homologous structures which represent the lymphatic vessels of the central nervous system. So this started changing our thinking towards how antigen presentation occurs in the central nervous system. Earlier, it was thought that the antigen mainly leaks into the deep cervical lymph node from the CNS, and antigen presentation occurred there, and then the immune responses occurred, and cells then, after being activated in the periphery, then gained entry into the CNS. But now a lot of it has changed. And that study led to another remarkable study by the same group, wherein they showed that the meningeal lymphatics fulfill two critical criteria, that is, they assist in drainage of CSF components and enable immune cells to enter the draining lymph nodes. And remarkably, they showed that ablation of these meningeal lymphatics diminished the pathology and reduced the inflammatory response of brain reactive T cells during experimental autoimmune encephalitis, which is the murine model for multiple sclerosis, which has remarkable, which has been very instrumental in understanding immune components of or immune biology of multiple sclerosis. And it was also shown in that study that meningeal lymphatics govern inflammatory processes and immune surveillance of the CNS. So now these lymphatics pose a valuable target for therapeutic intervention in autoimmune disease. So coming to role of the meningeal immune cells and brain function, in a healthy immune state, you see all these cells like the T cells, the B cells, the macrophages, the mast cells, all these present in the meninges. So and you have this healthy brain parenchyma here. But then in experimental models, when they knocked off these cells, especially the CD4 T cells, it was shown very clearly that the mice suffer from cognitive impairment, to show that how adaptive immunity is important for other functions in addition to immune function. So within the meninges, what are the kind of neuroimmune interactions that occur? So these are the meninges. Here you have the dura with all the different cells of the immune system. And you also have these newly discovered lymphatics which are present in the dura. And you have the leptomeninges here. And within the leptomeninges, you have the cytokine being secreted from the T cells, which are which influence the activity of the neurons here. And you also have within the leptomeninges the activation of T cells by antigen presentation, the CNS antigen presentation by MHC class 2 molecule to the CD4 TCR. And within the dural sinus, you can have again antigen presentation by MHC class 2 molecules to the T cell receptors here. And in the process of B cells getting activated during this antigen presentation, any autoreactive B cells can also be eliminated by apoptosis through these interactions. And most importantly, through this new discovery, it was shown that any CNS antigen present in the dural, now there is dural access to this, and these enter the lymphatics and then get presented in the deep cervical lymph node. So for any antigen presentation to occur and immune responses to be elicited, you need antigen presenting cells. And within the CNS, it's the microglia and the macrophages, mainly the border associated macrophages, which you call them, are important for antigen presentation in the CNS, along with many other cells as listed there. And these microglial cells are also considered as resident macrophages of the nervous system. And they're involved in phagocytosis, antigen presentation, and production of cytokines. So under resting stage, the microglia express certain receptors like the CD32 and CD64. And a lot of these receptors, including MHC class 1 and class 2, can get upregulated during inflammation when the microglia are activated. You may be familiar with these terminologies, the M1 and M2 microglia. Basically, the M1, M2 microglia are nothing but the pro-inflammatory microglia and the anti-inflammatory microglia, respectively. So whenever the resting microglia are activated, towards becoming a M2 microglia, they are more protective in function, and these secrete IL-4, IL-10, which are neuroprotective in nature. And whenever these microglial phenotype is converted into a M1 phenotype, it's more pro-inflammatory in nature, and these secrete more neurotoxic cytokines and chemokines. And astrocytes as well can be serving as antigen-presenting cells in the CNS, and they also can cause activation of both T and B cells. They secrete a lot of different cytokines and chemokines, and therefore they can initiate leukocyte migration across the blood-brain barrier and promote effector functions of immune cells. And this is another important feature of the CNS. We all are aware of the toll-like receptors, which are nothing but innate receptors, which sense a lot of different microbial ligands, and even some of them are known to be upregulated in autoimmune conditions involving autoimmunity to self-antigens. So the main difference is the microglia, which are the antigen-presenting cells within the CNS, where they express all the well-established toll-like receptors, mammalian toll-like receptors. But when you come to neurons, you have only a few of these being represented, similar to the astrocytes, a few TLRs being expressed, and the oligodendrocytes. So which makes it very evident that the microglia are the professional antigen-presenting cells and are most important when it comes to neuroinflammation during autoimmune disorders. So apart from this, now how does the CNS mediate or regulate the immune system? There are two important routes which are proposed. One is the hypothalamus, pituitary, and adrenal axis, which most of us are aware of, that suppresses the immune responses via the action of corticosterone here. And you have the another pathway, which is the sympathetic autonomic system that innervates the secondary lymphoid organs here, the lymph node and the spleen, and central nuclei, which is implicated in immune regulation. And with respect to neuroimmune crosstalk, both the neurons as well as the immune cells are known to express receptors for neurotransmitters as well as the immune mediators that are secreted by both the cells. For example, here, generally neurons communicate through neurotransmitters and neuropeptides here, and the immune cells communicate through mostly the cytokines, but you can also have cross interactions between the immune cells and the neurons, wherein both neurotransmitters and cytokines come into play, as shown here. So with respect to T cells in the CNS, how are they distributed? T cells are divided into different kinds of memory cells, basically, along with the naive T cells. Here the TN stands for naive, and the effector memory is TEM, the central memory is TCM, and you have that resting memory T cells called the TRM. So with respect to blood, you have the naive T cells, the central memory T cells, and the effector memory T cells, mostly going around in the circulation. But when it comes to the cerebrospinal fluid, you have more CD4 T cells than the CD8 T cells as shown here, similar to blood. But then the memory phenotype is mostly the central memory phenotype. And when it comes to the meninges, it's mostly the effector memory T cells which are present within the meninges, and within the perivascular spaces, the CD8 T cells predominate, and they are more of the resting memory T cell type. So those are the differences among different sites of the CNS with respect to T cells. And these are very elegant study which showed how the T cells within the dural sinus are present within the lymphatics here. The live one is the stain for the lymphatics, and you have the CD3, which is stain for the T cells. And as shown here, and this is the stain for the nucleus. And here you see that the lymphatics and the T cell staining merges very well, showing that the T cells are present very much in the meninges during the steady state. And during health and disease, what's the role of these meningeal T cells? So they can regulate different neurobehavioral functions, cognitive function, as I said earlier. They can also influence social behavior regulation and anxiety regulation. Along with that, during pathological conditions, during neuroinflammation, T cells can secrete a lot of pro-inflammatory cytokines, resulting in neuroinflammation. So basically, T cells can control infections, like some of the viral infections, through their cytokines, secreted by activation through microglia. And they can also control autoimmunity, basically the regulatory T cells, which can suppress the Th1 and the Th17, which are pro-inflammatory phenotypes of CD4 T cells. The Tregs can block their activity and control autoimmunity. And they also are neuroprotective in nature. The Th2 cells, along with their interactions with microglia, can secrete IL-4, which can be protective in neuroprotective in neurodegenerative diseases. And coming to neuroinflammation, whenever there is a breach in the blood-brain barrier, like here shown in the diseased CNS, you can have neuroinflammation occurring, and all these cytokines are cause loosening of the tight junctions, and the immune cells, basically the B cells, the T cells, the macrophages, gain entry into the CNS. You see this astrogliosis here, resulting in neuroinflammation, which is shown here how the T cells, the immune cells, gain access to these lymphatics and result in antigen presentation and immune activation. Here, the model of experimental autoimmune encephalitis in the murine model, which represents the MS model for explaining the T cell activation. You see that the deep cervical lymph node on the EAE is induced by injecting MOG into the mice, and once the T cells are activated, you find these inflamed deep cervical lymph nodes, which are seen in these lymph nodes, which gain entry into the circulation and then infiltrate into the CNS and cause neuroinflammation. Basically, how these cells gain access to the dura through the lymphatic vessels, as shown in this picture, through these extensions in the lymphatic vessel. Now, all this is novel understanding after the remarkable discovery in the Nature paper that I mentioned. And what are the T helper cell subsets that are involved in CNS inflammation, and what happens to them post-inflammation? For example, a naive T cell can differentiate into a Th17 cell or a Th1 cell, which are pro-inflammatory in nature. They can get into the CSF and enter the brain. During inflammation, they secrete a lot of IL-17, which brings in a lot of neutrophils and cause CNS tissue damage. But then during recovery, it is shown that these cells are plastic in nature and can convert themselves into regulatory T cells. And similarly, the Th1 cells can, during the recovery stage in neuroinflammatory disorders, at least in the mouse models, are shown to take up a regulatory phenotype. during recovery mode. How do these T cells gain access to the CNS during neuroinflammation? So like peripheral inflammation, they stick on to the blood vessels through various adhesion molecules and their receptors. And then finally, through diapedesis, they get into the perivascular space and gaining entry into the parenchyma finally during neuroinflammation. And what about B cells? So B cells are mainly located in the skull bone marrow here and within the meninges and also within the choroid plexus as shown here in the normal CNS. And they also have pro-inflammatory functions and anti-inflammatory and neuroprotective interactions wherein they secrete cytokines which can actually activate pro-inflammatory cells like the myeloid cells, the Th17 cells, Th1 cells, and the dendritic cells. And in the neuroprotective function, they mainly secrete regulatory cytokines or immunosuppressive cytokines. So the B cells mainly have three domains of function: antigen presentation, and they secrete cytokines, and antibody production. As we know, they are capable of producing different kinds of antibodies. And during neuroinflammation, they secrete a plethora of cytokines, which can impact the activity of T cells, macrophages, and astrocytes. And when they gain entry into the CNS, these activated B cells can produce lots of antibodies, which can either result in antibody-dependent cellular cytotoxicity or complement-mediated death, killing of neurons during neuroinflammation. So B cells are, we know, are implicated, are clearly established to have a role in multiple sclerosis, and then you have in MOGAD, in NMOSD, and NMDR encephalitis, a few conditions shown here, and in myasthenia gravis, wherein they are known to secrete self-antigen antibodies. So they can contribute to CNS disease either through periphery, which is called an outside-in effect, resulting in CNS immunopathology. And most importantly, the success of B-cell depleting therapy in patients with MS and CNS diseases with an autoantibody component, such as NMOSD and autoimmune encephalitis, highlights the role of B-cells in both cellular and humoral-mediated CNS conditions. So emerging evidence also suggests that B-cells contribute to pathogenesis of neurodegenerative diseases. And to just briefly tell you about the glymphatic system, so it's a pseudo-lymphatic perivascular network distributed throughout, responsible for replenishing as well as cleansing the brain. And they are formed by astroglial cells to promote elimination of soluble proteins and metabolites from the CNS. So impaired glymphatic clearance has been linked to neurodegenerative diseases. So this is the structure of the glymphatic system, which has been shown here. So basically, it's caused, the interstitial fluid is being, there's efflux of solutes and other macromolecules which are getting into the CNS and drain out. And they may also be, draining out antigens, which are important for antigen presentation and immune responses. So in the young, you have a very efficient glymphatic function. And in the old and the Alzheimer's disease, you see here the passage of all these toxic molecules are in the, is impaired in Alzheimer's disease. So these are some autoantibody targets in autoimmune encephalitis syndromes, which you are all familiar: the NMDA receptor, the LGI1, Casper, and a few others which you're all familiar with. And they all can, each of these can result in different clinical manifestations. And there are certain T-cell associated CNS diseases, mainly multiple sclerosis, Rasmussen's encephalitis, and paraneoplastic syndromes, where even B cells are known to be involved. And you have some T cell phenotypes wherein the Th17, the CD8 T cells, and the which are involved in neuroinflammation here. And these are certain conditions where both T cell activity and antibody associated CNS activity is seen in CNS diseases. NMO, acute disseminated encephalomyelitis, and NMDR encephalitis, where you have both T cell activity, which is established, and you have specific antibodies against autoantigens, which has been clearly established. And the therapeutics, the approaches of B cell depletion, which is a common approach. It can be immunomodulation and cell therapy, which is an upcoming mode of managing autoimmune diseases. So CAR T cell therapy for multiple sclerosis has been approved for clinical trial in the US, and these are the immune cells to treat autoimmune disease here. So you see the CAR T cell therapy, which is the clinical trials, which has gone up over the years. You can see for multiple sclerosis and other disorders, including myasthenia gravis. So, which is a very exciting mode of approach. And this is just to show that, in B cell depletion therapies, that it's in a single individual, multiple doses of rituximab given here. But for repopulation, the time for repopulation is almost the same, about 6 months here. Basically, which means monitoring B cells is an extremely important feature of managing these disorders. So I'll come to that a bit later. This is something which we have done in NIMANS. The MAID cells, which I told you, which are gaining a lot of importance as innate T lymphocytes. So I work with Dr. Netra's student, Dr. Hari Krishna, which was done. We showed that MAID cells are depleted in neuromyelitis optica as compared to RRMS and the healthy controls here. And we also have an ongoing study on NMOSD where the T follicular helper cells and Tregs and functions of these are being, we are trying to understand in NMOSD. And thanks to Dr. Netrawati's motivation 2 years ago, and now we started this CD1920 based monitoring of B cells by flow cytometry for our patients. You see that as compared to last year, this year the numbers of samples that we have received for testing is constantly going up. And you all very well know across the country that the diagnostics for these autoimmune disorders are provided by Professor Anita Mahadevan's Autoimmune Laboratory in the Neuropathology Department at NIMANS. And with that, I would like to thank you all for your kind attention. And I especially Dr. Netra for this invitation and all my colleagues from neurology and the autoimmune lab of Dr. Anita Mahadevan and my colleagues, Ms. Pavitra, Ms. Lakshmi, and the team which support in B cell typing and running the flow cytometry, and CSR donation for having a clinical flow cytometer at NIMANS, which was a project of Rotary Palmville. With that, I end my talk and I'm ready to take questions. Thank you.
Thank you, Dr. Manjunath. I think you brought out very well about, because initially we used to think all these immune-mediated disorders were T-cell mediated, and how the B cells also come into function. I think you brought out very well. Thanks.
Thank you.
We could take some questions. I request all the attendees to please post their questions in the chat box so that we can take them. After each talk, we'll have 5 minutes where we can have some discussion, and then we'll be going to the next talk. Dr. Rohit, you would want to tell something?
I think thank you, Dr. Manjunath, for giving this wholesome understanding about how the various cells and the lymphatics knowledge that has evolved have an interplay to cause immunoinflammation, and of course, how we can target them with various disorders. So I think the field has evolved further with the advent of more of specific drugs that target these specific, markers on specific cells, B cells. And we currently, of course, I don't think practicing a lot of CAR T cell therapy, which is still, I guess, in a process of evolution. Over time, I think myasthenia gravis is one disease where it is probably showing a faster evolution, but I'm sure as we understand our diseases better, its evolution to treat them will also increase with time. So my question to you, Dr. Manjunath, is that we as clinicians and as the science has evolved, for doing what we call rebooting of the immune system, are doing autologous hematopoietic stem cell transplant we are offering to patients who are failing more than 1 or 2 second line therapies, and we feel the disease is something that we need to control. So any would you like to comment on what this hematopoietic stem cell transplantation may be doing to our immune system, that it really helps to load down the disease activity?
Yeah, I mean, I believe this is more, the stem cells are taking up regulatory role. They're differentiating into more regulatory kind of immune subsets. Mostly the Treg subset, possibly. And as I told you, the innate T lymphocytes, which are gaining more attention here. So now these are possibly influencing these innate T lymphocytes. They have been neglected for a long time, and these innate T lymphocytes have been are present in quite good numbers in our peripheral blood. So I believe, yeah, I mean, it's not a easy puzzle to solve, but yeah, my strong belief is these cells are also involved in improving conditions based on stem cell therapy.
One question is there from
Yeah.
Dr. Arnish Bhattacharya, who asks about the role of BTK inhibitors. We know that when we give CD19, we monitor when we give rituximab, monoclonal antibodies, but BTK inhibitors is an upcoming therapy. So is there any role of CD19 monitoring in these group of drugs?
I'm sorry, I'm not aware of that aspect. So if, yeah, as
Okay.
clinicians, if you are aware, yeah, I would.
So basically,
Yeah.
BTK inhibitors are completely different from the other medications what we have. The pathway is different, more directed towards the peripheral. And so they are not monoclonal antibodies. So when we have monoclonal antibodies are the type when we require the CD19 monitoring. Like, for example, we have alemtuzumab where we have anti-CD52, rituximab, and iblutiximab. So all these monoclonals will be targeting some part of the CD. So there we require monitoring and not for the BTK inhibitors.
I think if we don't have any more questions, Netra, can we move to the next talk?
Yes, Dr.
Thank you. Thank you.
Thank you,
Thank
Dr.
you, Dr.
Once
Manjula.
again. So our next talk today is about moving on from the basic understanding of how immune system was working. Our next talk is from on the immunological behavior and immunobiology of two important serologically driven diseases, which is NMOSD and MOGAD. So I now invite Dr. Kamakshi, who's a senior consultant in Department of Neurology at Max Vaishali. She's also a postdoc fellow, done her CNS demyelination immunology postdoc from NIMHANS Bangalore, and has a special interest in the subject of demyelinating disorders. And I've also had a experience of working with Kamakshi as a part of a national MS registry, and she has an ardent interest in this subject, and we invite her to now give us an overview of how the immunology of MOGAD and astrocytopathy works. Thank you, Dr. Kamakshi, and over to you for the talk.
Good evening, everyone, and thank you, sir, for the kind introduction. I would like to thank ma'am and sir both for giving me an opportunity to take up this topic. I'm just going to share my screen now. So, is the screen visible?
Yes, Kamakshi.
So I will be talking today on the immunology of astrocytopathy, particularly the aquaporin 4 antibody disease and the MOG antibody disease. So as we all know, neuromyelitis optica, the aquaporin 4 antibody disease, is an inflammatory disease of CNS, which is clinically characterized by one of the core clinical criteria, which include optic neuritis, myelitis, area postrema syndrome, brainstem syndromes, diencephalic syndromes, or symptomatic cerebral syndromes. So ever wondered what is the actual difference of NMO from what makes it different from MS? Now we all know that NMO is a disorder which has a more severe visual, motor, and sensory disability than MS. There is a persistent absence of OCBs in the CSF, and we get more frequent pleocytosis and lymphocytosis in CSF. So what all features they characterize NMO so differently from MS? We know NMO is a severe phenotype. Pathology-wise, it has a massive demyelination. There is extensive tissue necrosis and profound cavity formation and inflammation. So to understand the pathology of aquaporin, I think we should go back to the history and understand how it was discovered. So he is Sir Eugene Devick, which we know Devick's disease by his name. He was the first person to describe an autopsy-proven case of neuromyelitis optica. He described a female who had both optic neuritis and a transverse myelitis, and pathologically, the autopsy showed a severe demyelination, a severe necrosis in the optic nerve and spinal cord, but there were no brain lesions here. So his student, who was Sir Fernand Galt, he worked on this topic and he compiled around 17 cases, including the case which was described originally by Eugen Devick. And he made the characteristic feature along with the features which were described by Eugen Devick to include some brain lesions as well. So over the years, the researchers have understood that it is a phenotype which is severe. The optic neuritis is severe. The myelitis is severe. Over the years, the concept emerged that monophasic cases probably are Devick's disease, but the relapsing cases are opticospinal MS, especially in Asian population. Both of them, Sir Fernand Galt and Eugen Devick, combinedly, they originated the term neuromyelitis optica. So by that time, we did not have a serological diagnosis. It was in the year 2004 when Sir Lennon discovered that there was some specific antibody in the patients of NMO. And when he did some immunofluorescence analysis, he found that this immunofluorescence staining antibody is found across the pile membranes, especially into the cerebellum and the midbrain. It lines the pile surfaces very beautifully. It is found into the perivascular structures. It lines the Virchow-Robin spaces and covers the pia of the midbrain also. So the characteristic staining pattern, it told us that it was a vasculocentric pattern. It was a disease where there was a specific deposition of IgG, IgM, and complements, and the pattern suggested that there was some pathogenic antibody which was giving this pattern onto the immunofluorescence here. So this was the first time that an NMO antibody was found, and it was described that this was an antibody-mediated disease. Now we understood that this was an antibody, but what was the antigen? So again, the next year, he published another observation of his, and he concluded that this NMO IgG is basically an antibody which binds to the aquaporin 4 water channel, specifically which is located onto the astrocytic foot processes at the blood-brain barrier. So this was the probably first example of an autoimmune channelopathy. Now, we know aquaporins are widely distributed into the body. There are 13 classes of aquaporins which are there. But specifically, brain has two classes, aquaporin 1 and aquaporin 4. Aquaporin is a protein which consists of 6 transmembrane proteins. They circle around themselves and they form this sort of a structure which has a pore in between the two subunits, and it allows the inward and outward flow of water molecules along them. So Sir Lennon, what did he do was, he saw that in the brain, apart from the brain, where all do we get this antibodies? So he used these antibodies across various body tissues, including stomach, kidney, liver. It was found nowhere except in the brain, the distal urinary collecting tubules, and the parietal cells. So the combination of these three positions, that is the brain, the distal urinary tubules, and the parietal cells, the only thing which would come was aquaporin 4 here. So aquaporin 4 was the candidate antigen, which was described as being responsible for being as an antigen for the aquaporin 4 antibody. That was how it was discovered as the incriminating antigen. So this was his study. The classical NMO IgG pattern we can see distributed along the pile surface in the brain, along the distal urinary tubules, and the parietal cells of stomach. This was the aquaporin 4 antibody staining, which was found in a similar pattern. And when the two patterns were superimposed, exactly the same pattern came. So that is how aquaporin 4 antibody the antigen was discovered. So we know this is the classical blood-brain barrier. We can see the astrocytes here, the astrocytic foot processes, the blood-brain barrier, which is constituted by the endothelium, the pericytes, as well as the astrocytic foot processes. Now, along these astrocytic foot processes, this is the aquaporin channel, which is responsible for the to and fro motion of the water molecules across the membrane. So this is how the water molecule inflows as well as outflows. This is a monodirectional monogram, but actually the flow is bidirectional. It is controlled along to the osmotic permeability of the membrane. So aquaporin channels, they are basically located along three very important structures in the brain. One is the blood-brain barrier, which we have seen. The second is the ependyma, where it controls the formation of CSF, and along the glia limitans, where it controls the absorption of CSF also. So this concept is very important to understand because these are the locations where aquaporin 4 is concentrated. And along these surfaces only, we find radiological NMO lesions as well. Now, astrocytes are the supporting structures inside the CNS, but how does the myelin get damaged? Myelin is what is produced by the oligodendrocytes, but astrocytes are very important supporting structures for the neuroaxon as well. So we see here that this astrocyte is giving support from the blood-brain barrier to the neuron, and there is crosstalk between the oligodendrocytes as well as the astrocytes. So possibly in astrocytopathy here is giving a secondary demyelination. So astrocytopathy giving rise to a secondary demyelination is the core concept of development of CNS demyelination in NMO spectrum disorders. Now, this is a roadmap which depicts a sequential steps towards development of a clinical NMO lesion in a patient. Now, basically for any CNS demyelinating disorders, there are few steps which leads to a clinical production of a symptom. Starts from the genetic predisposition, then some triggers happen, then there is some immunological switch which leads to generation of aquaporin 4 antibody. Aquaporin 4 antibody is not permeable with blood-brain barrier. It cannot cross. Only in situations when blood-brain barrier is compromised, it crosses the blood-brain barrier and finally attacks on the astrocytes. Now coming on to the genetic predisposition. Now see, NMO has been found to be relatively more prevalent in non-Caucasian populations as compared to the Europeans. There are numerous publications about the familial neuromyelitis optica as well. Now, this was a case series of nearly 12 NMO pedigrees with a total of 25 affected individuals. So all those studies, they tell us, although the factors might not be very clear, but there is definitely a genetic predisposition which somehow alters the immunoregulation milieu within the body and predisposes the patients to develop an NMO spectrum disorder. Especially even in some geographical associations, there are different HLA associations among the NMO population. So genetic predisposition is a prerequisite to develop any autoimmune disorders, and we have some evidence for this existence in NMO as well. Now the second step is you have a genetic predisposition. What triggers this autoimmunity? Triggers in the form of any viral infection, any bacterial infection have been found to be present in up to the tune of around 30% of the cases. And these immune triggers have been found to be some viral infections, CMVs, dengue, hepatitis A, HIV, VZV, Epstein-Barr virus, and numerous viral antigens have been found to trigger the onset and probably in recent time COVID also, to trigger this sort of autoimmune response in the body. Even in papillomavirus vaccinations, aquaporin antibodies have been found in a paraneoplastic context as well. So all these things tell us that some sort of trigger occurs in the setting of a genetic predisposition, which predisposes an individual to develop the NMO spectrum disorder. Now, one thing has to be noted clearly that this aquaporin 4 antibody has an extrathecal synthesis. That is, the plasma B cell give rise to aquaporin 4 antibodies extrathecally, and they enter into an in the CNS site after crossing the blood-brain barrier. It is a very important concept to understand. I will be covering in the next few slides. Now, there have been studies which actually prove that it is an extrathecal synthesis and not an intrathecal phenomenon. So people have found by pairing both CSF and serum samples and calculated the percentage and the indexes which can tell whether this is a real intrathecal synthesis or not. And most of the studies have found no evidence of this intrathecal synthesis in their analysis. Studies say that if the patient has a CSF antibody aquaporin positive, then the serum antibody titers must be 500 times more in the serum to be detectable in the CSF. So this is how it happens. There is an extrathecal synthesis of the antibodies, and this extrathecal synthesis then crosses the blood-brain barrier and reacts into the CNS. Now, when this plasma cells, they generate the aquaporin antibodies here, IL-6 is one molecule which is very important. How we will understand in next few slides. Now, IL-6 is one neurochemokine which is very important both in the periphery as well as the CNS, and it has a multitude of steps involved in the NMO pathogenesis. Now, once the aquaporin 4 antibodies are formed, it has to cross CNS. It is impermeable to an intact blood-brain barrier. Now, how aquaporin 4 enters into the CNS? Probably aquaporin 4 itself is pathogenic to the blood-brain barrier and it alters the blood-brain barrier permeability somehow. There are some other hypotheses which also tell that apart from aquaporin 4 itself, there are some collateral antibodies, some chemokines which sort of predispose the permeability of the blood-brain barrier so that these immune cells, the antibodies, can enter into the CNS. Now, finally, they attack on astrocytes. Now, the next question is aquaporin 4 pathogenic in itself? So, aquaporin 4 is something which is expressed in non-CNS tissue, but there is no pathological involvement of extraneural tissues. The pathogenic potential is exclusively limited to CNS, however, in a specific CNS milieu. The immunological, the antibodies which we detect in the periphery are IgG1. But in the brain lesions of NMO, we find predominant phenotype of immunoglobulin to be IgM. This IgM is present in only 10% of patients in the serum. So probably the IgG1, it enters into the CNS and undergoes some sort of class switching, and the lesions have a predominance of IgM phenotype. However, studies have shown that apart from IgM, IgG deposition is also there, which says that IgG is a pathogenic antibody in aquaporin disease. It has a very high specificity and there are probably no false negatives. So, how does this aquaporin antibody, it actually causes the substrate level problem to astrocytes? So, two important pathways for injury of aquaporin antibody to the astrocytes is probably first would be an antibody dependent cell mediated toxicity, which I think we all are aware of. And the second is the complement mediated cytotoxicity. However, apart from these two pathways, another third pathway has an important existence in the pathogenesis, which says that apart from the complements and antibody dependent pathways, probably because aquaporin 4 antibody, it damages the astrocyte and the oligodendrocytes are present in the vicinity. So once the aquaporin 4 has attacked onto the astrocytes, there is oligodendrocyte injury and demyelination, there is granulation, glutamate excitotoxicity, and finally it damages the oligodendrocytes here as a bystander injury rather than the actual phenomenon. So oligodendrocyte damage, it appears to follow immune-mediated astrocyte injury. It is the second step. The first step remains astrocyte injury. Glutamate excitotoxicity is a potential mechanism for basic oligodendrocyte injury in astrocytopathies. And we have the evidence that even in patients who have acute NMO relapses, the CSF GFAP levels, GFAP is an astrocytic cytoskeleton molecule, which is found to be at very high levels as compared to relapses in MS. So once we cross all these 5 steps, the many symptoms get manifest. So after a brief introduction of the NMO spectrum disorder, especially limited to the aquaporin disease, I'll be touching on to some key differences between aquaporin and the MOG antibody disease as far as the immunology is concerned. So MOG protein, this is the outermost protein of the myelin sheath. It constitutes around 0.05% of the total myelin proteins, and it is basically involved in the oligodendrocyte stability. So as we can see in this cross-section of the axon, this MOG molecule is the extreme outermost covering of the myelin sheath. Here also it is depicting the same. So one important concept to understand is now aquaporin for NMOSD is an astrocytopathy, whereas MOG antibody disease is an oligodendrocytopathy. It is completely different from MS and aquaporin, which we know as of now. Now, same way, I think before taking up the immunology, it is important to understand how this was discovered. Now, in initial very few descriptions dating back to around 1980s, this MOG was identified to be a CNS protein on the surface of oligodendrocyte. By that time, that was known as M2 molecule. Now, when it was initially discovered, it was more often viewed as a risk factor for conversion of CIS to MS. And people actually have conducted studies where they have seen that the patients who have antibodies to MOG and myelin basic protein with clinically isolated syndrome, they more frequently convert into MS. So that was the initial value of MOG as a biomarker for conversion of CIS to MS. However, subsequently, there was a noise that these MOG antibodies are not specific because they are found even in patients of MS. They are also found in patients who are with control subjects. However, I would like to mention here that Connor was the first person who hypothesized that whenever we do experimental studies related to MOG protein, we were utilizing the linear epitopes. That means the assays which were used to analyze these MOG antibodies were the linear epitopes. We use ELISA or Western blots basically, which denature the proteins. And what we identify on these assays is a linear epitope. However, if we use a confirmation epitopes for the human IgG MOG, these antibodies, they are not non-specific. And they were found in patients who were non-MS more frequently. They were found in patients who had ADEM more frequently than MS. That means somehow something was going wrong with the method of identification of this antibody. That is, if we use ELISA, if we use Western blot, it has no value. If we use cell-based assays with immunofluorescence, utilizing antibodies for confirmation epitopes of human MOG protein, those assays are they have a better specificity rather than ELISA and Western blot proteins. So it was again later on seen that such presence of such confirmation antibodies for the confirmation epitopes of MOG, this was found in patients who were phenotypically NMO, non-MS, but they were seronegative for aquaporin. So they were found to have a higher frequency of seropositivity for MOG antibody. So pathologically, MOG has, there are various patterns of demyelination which we see in MS, aquaporin, MOG. MOG is something which gives a combination of patterns. There is some pattern of confluent demyelination, some pattern of this perivenous demyelination. However, important to understand here is the brunt of demyelination, it spreads from the subpile cortex and to the deep gray matter. The frequency of cortical demyelination in MOGAD is very high as compared to MS patients. It has a very important clinical prerogative, which I will be discussing later. So the main target of immune attacking is myelin and MOGAD, but it is astrocytes and aquaporin 4 antibodies. So similarly, as we have understood for the aquaporin disease, the same holds true for the MOGAD also. However, there were two very important differences between NMO and MOGAD. Here comes the extrathecal synthesis point in the attack on oligodendrocytes rather than the astrocytes. So there is an outside-in theory for MS also. MOGAD also respects the same. That is, Here also, there's an extrathecal synthesis of MOG antibody by dysregulated immune system, which probably has a genetic predisposition, some triggers, which leads on to generation of these MOG antibodies. Now here we can see once these MOG antibodies are formed, they cross the blood-brain barrier and gain entry into the CNS. So that is what extrathecal synthesis of MOGAD is there, and it is not an intrathecal synthesis. However, this is something important, different aspect from NMO. That is, we have seen that CSF aquaporin positivity doesn't hold any value. However, there is a subset of MOGAD patients who phenotypically are MOG, they are clinically MOG, but they are seronegative. So in these patients, researchers have found value of testing for CSF MOGAD as well. So the relative quotients of aquaporin versus MOG, the CSF versus serum, MOG quotients are probably higher than the aquaporin quotients. That means some amount of intrathecal production of MOGAD is possible, and it occurs more frequently than the aquaporin disease. That means patients who are high suspects for MOG phenotype but are seronegative, CSF testing may add to the results. So it has an important therapeutic connotation as well. The study has found that the patients who are CSF MOG positive, they have a more severe clinical presentation and a worse odds for recovery at 6 months as compared to patients who were negative in the CSF. So this is how the MOG protein and the MOG antibody enters into the CNS and damages onto the oligodendrocyte. Here we can say the surface of the oligodendrocyte, the outermost sheet, the MOG antibodies are attaching to it and they cause the oligodendrocyte damage. So here also it is the IgG1 subtype. So see, B cells are important part of the disease pathogenesis here. However, by experience, we now know that anti-CD20 therapies are relatively ineffective in MOGAD as compared to the aquaporin disease. This suggests that T cells may play a pivotal role in MOGAD pathogenesis as compared to patients with the aquaporin disease. So coming on to the clinical implications of whatever immunology which we have seen till now. So pertaining to the aquaporin disease, probably there is a severe clinical presentation accountable to a worser demyelination phenotype on pathology. Now, since we have seen that aquaporin is limited to the periependymal distribution into the CNS, this is how the radiology of NMO looks like. It is concentrated along the periependymal surfaces everywhere. Callosum, hypothalamus, periaqueductal area, area prostrema, third ventricle, the periaqueductal area, and the optic chiasm. This is all where the aquaporin protein is highly concentrated. So that is the second implication of understanding immunology. The third is when we test for aquaporin 4, probably CSF testing has not got a value. Serum aquaporin 4 testing, that is what should be ordered for. The next implication is we have understood that it is an extrathecal synthesis. So plasmapheresis is a wonderful modality to treat acute relapses of aquaporin as compared to MS, probably because the synthesis of antibodies is extrathecal. Then finally, coming on to the therapeutic implications, this is the pathway, how the aquaporin disease occurs and it is managed. We have various therapeutic targets. First, we very frequently use monoclonal antibodies, rituximab. We know it acts onto the CD20 cells, decreases the production of pathogenic antibodies. This IL-6, which we have discussed shortly, tocilizumab is a wonderful molecule for these patients because it affects the interleukin-6 in multitude of ways. We have plasma exchange because it drains the burden of aquaporin 4 from the body. And then finally, into the intrathecal system, we have complement inhibitors, like eculizumab, which inhibits the conversion of C5 to C5a and B. And we have in pipeline directed monoclonal antibodies against the aquaporin antibody as well. So understanding the immunology, I think it lays the foundation for understanding the therapeutics as well. A brief word on rituximab in NMOSD. So rituximab we use very rampantly. We understand that rituximab is clinically effective in aquaporin disease, and it reduces the levels of aquaporin as well. But the antibodies do not completely disappear with treatment. Now, whenever we give the patients rituximab, start the patient with rituximab, there is a risk of worsening 2 weeks after the first injection, probably because rituximab acts on CD20 cells, which the plasma cells they do not have. However, memory cells and regulatory T cells, they get blocked with this antibody. So what happens is, as a paradoxical response to the depleting B cells, these B cell activating factors, they get released into the plasma, and that acts as a stimulus for increasing factors for the B cell pathway, and hence some sort of worsening is possible with initial rituximab infusions. So repeated rituximab therapy may reduce the level of NMO antibodies in the serum, probably because the memory B cells, they get depleted over time. However, we see that there is a percentage of patients who do not respond to rituximab, probably because some long-lived plasma cells may continue to secrete the autoantibodies despite the treatment with rituximab. So coming on to the clinical implications of immunology in MOG antibody disease. Now, first is, we have seen that the MOG antibody, is more cortical in location. So cortical phenotypes of MOGAD are, the cortical presentations are commoner in MOG antibody disease. I'll be covering it in the next slide. The second is, serum MOG testing carries a value, but in rare instances, CSF MOG testing should be carried out in high suspect, especially in CSF restricted anti-MOG phenotypes. The third is, ELISA Western blots are not preferred techniques for testing for MOG antibody, and cell-based assays should be preferred because they target the conformational epitopes for recognition. MOG antibodies, low titers in adults have a low predictive value than higher titers and should be interpreted with caution. Now, we know that MOGAD has a spectrum of radiological presentations. Among these, I would like to emphasize that ADEM-like presentations, flames, that is the flames and fuel pattern where we see a cortical encephalitis-like presentation, and the meningeal patterns, they are very common with MOG. And we now understand, because the abundance of these pathologies into the cortical surfaces is probably the reason why we see more of ADEM, more of flames, cortical encephalitis in patients with MOG disease. So the conclusion here is, immunology paves the way to understand the dynamics of clinical presentations and the treatment responses in CNS demyelinating disorders. Thank you so much. Over to you, sir.
Thank you, Kamakshi, you for covering it so well. Complex disorders with complex immunology, a lot of overlap and interplay between these two diseases. And as you rightly said, in some of the patients, we do have still defined ways to say seronegativity in NMO, but we still don't have such terminology yet accepted in as a seronegative MOGAD. And I think I just wanted to ask you one question, and there is another. I think we'll take the question from the audience first. So there is a question about conformational assay. Madhuri has asked, please explain conformational assay.
Whenever we use assays which denature proteins and lead to the formation of linear epitopes, as in ELISA or Western blots, that is. I'll go back to, so can I share my slide once?
Yes, please go ahead.
So that is a linear epitope where we see if the protein is denatured, we get a linear portions of the molecules being tested onto these assays which denature proteins. However, originally these proteins are not in this shape in our body, and they are in a definitely conformational phenotypes inside our body. That is, when we denature the protein, we get linear epitopes, but inside the body, they are into some three-dimensional conformation, which is the actual structure of the protein. So that is what the ELISA and Western blot does. It denatures the proteins, but it does not identify the protein into the which is like the original form which is present in the humans. The conformation epitopes, it is an epitope which is directed towards the three directional conformation which is originally present in the human body, and that is why this has a more specificity. Whenever an assay utilizes this conformation epitope recognition, it has a more specific value as compared to the assays which recognize a denatured protein chemically.
Okay, so there is another question, which is, of course, um, intuitive, that when a patient is positive for MOG, they will fall under NMOSD or MOGAD. Is it based on MRI? So I think you can clarify that, Kamakshi.
So probably when this MOGAD was discovered, it was very frequently thought that MOGAD and aquaporin, they are a spectrum. But now we understand that the pathology of NMO and MOGAD are completely different. That is why clinically also, radiologically also, there are so much differences between the two entities that grouping them together would be an injustice for both of them. Pathologically, they are both different entities.
So if there is a patient that you are treating as demyelination, and you have already decided that it is a non-MS phenotype clinically, and you are now looking at a serological diagnosis, and you feel that most of the findings do favor either the NMO or a MOGAD, and you get a MOGAD positive and it fits well into the clinical features, and you will have to call it a MOGAD disease based on even the current consensus criteria. So there should not be, yes, where you are uncertain and you think that the clinical picture is fitting into multiple sclerosis, we do see sometimes false positive MOG in such patients. So there you have to use a composite of clinical imaging and your own understanding of the case where you best would like to fit this patient. So there are, of course, false positive and false negative cases as well. So there is another question, Kamakshi. That's probably the last question. I think we do have 2, 3 more, but I'll just club them. So one is that if it's an extrathecal synthesis, then why? So the question is basically directed at why there are no peripheral symptoms usually in NMO MOGAD. And I think the same true holds for MS to a large extent.
So as far as the aquaporin disease is concerned, it is not like that. It is not present the expression is like it is there in other body tissues as well. But that is why I explained that when this antibody was discovered, that is how the researchers came to the conclusion that this antibody is pathogenic to CNS only. Expression is wide, but the pathogenicity is in the CNS. This is true for aquaporin disease. But as far as MOG is concerned, I think we have now some clues that MOG antibody disease does affect peripheral nervous system as well, where we find some sort of radicular involvement um, for the peripheral nervous system also. So probably that will need more research how and what frequently we find peripheral nervous system manifestation with MOGAD. But as far as aquaporin is concerned, it is pathogenic only for the CNS and not for the peripheral nervous system at all.
Just one last question about how this would differ in children compared to adults. And we all see that children have slightly varied presentations compared to adults, which may have more of the usual presentation. So if you can just throw some light on that, Kamakshi.
So what is the exact question here?
Question is about difference in children of a MOGAD presentation compared to adults.
Probably MOGAD presentation, pediatric ADEM-like presentations are very common in MOGAD, whereas the spatially limited forms like optic neuritis or myelitis, these forms are commoner in patients who are adults with MOGAD. In pediatric patients with MOGAD, especially who have ADEM, this is ADEM on phenotype in which the patients who present pediatric age presenting with ADEM, however, subsequently switching to optic neuritis later on is also common. Leukodystrophic-like patterns of MOGAD, they are commoner in the pediatric population as compared to the adult populations. So this is the basic, some differences in the the age groups between the MOG disorders.
I think we've covered most of the questions. We would probably be happy to discuss much more on these interesting diseases. But for the lack of time, we'll have to move on to the next talks. Thank you very much, Kamakshi, for your excellent presentation. And I think interesting questions also. We're learning more on these disorders as we're evolving to understand them better. So, Dr. Netra, I now request you to please call on the next speaker.
Yeah, thank you. Thank you, Dr. Kamakshi. Now we have the next topic where we will be talking on the immune disorder, the basic functions in multiple sclerosis, which is the most important topic. So this will be conveyed by Dr. Prabhakaran, who is Professor of Neurology at Department of Neurology, CMC, Vellore. So he has a lot of publication, especially with robotics, stroke, cognition. I've been to his lab and you should see the cognitive testing, what he does. It's really marvelous. Many of the tests he has evolved himself and does really good work. He's part of the MS registry from CMC Vellore. Over to you, Dr. Prabhakar.
Thank you, ma'am. Thank you for your kind introduction. I'll start by sharing my slides. Slides, ma'am?
Yes, same Prabhakar. You have to do, yes.
Yeah. So good evening to all of you. I'll be discussing the immunobiology of multiple sclerosis. Multiple sclerosis is a multifactorial autoimmune disease that affects the central nervous system, and its immunobiology is one of the complex things that's been studied over the years and still remains to be controversial in certain aspects. So I'd like to tackle this complex issue by trying to understand it from a clinician's point of view. So any complex disease as a clinician could be understood in terms of the epidemiological triad. So if you look at the epidemiological triad, you have agent factors, you have environmental factors, and you have host factors. Multiple sclerosis can be seen as an autoimmune disease that happens to people who are genetically predisposed in the presence of environmental triggers. So in this context, let's start by looking at the agent factors. The agent factors that have been strongly associated with multiple sclerosis over and again is Epstein-Barr virus. So Epstein-Barr virus increases the risk of multiple sclerosis almost by 32 times. And that too, if you're likely to get an EBV infection later in life, even after the first decade, and if you develop clinical infectious mononucleosis, you're likely to you have a higher risk of developing multiple sclerosis. And also this EBV is known to infect the immune cells, especially B cells, which seems to be the current hypothesis as a causal role in the development of multiple sclerosis. We'll be coming to that as we talk about the immunopathology. There are other viruses that have been associated with this. The other virus that has been associated is the HHV6, where high levels of IgG antibodies against HHV6 has been seen in both RRMS and PPMS. Coming to environmental factors, strong associations been with cigarette smoking, obesity, diet, and changes in the gut microbiota, where certain microbiota are associated with increased risk, and certain things that are produced by gut microbiota, like the short-chain fatty acids, are known to be protective, whereas low vitamin D, air pollution, and some organic solvents have a moderately increased risk of developing multiple sclerosis. The most important thing is genetic predisposition. Almost 30% of patients have genetic predisposition, and this is seen because it's an immune-mediated disorder. A lot of it is with the antigen-presenting cells themselves. So a lot of the mutations seen are in the class 2 antigen. And you can see that the HLA class 2 antigens, here are the lists of some of the alleles that are associated with increased multiple sclerosis risk. Mutations in class A antigens are associated with increased risk, whereas the other loci in class 1 are seen to be protective. Apart from these, there are more than 200 loci of SNPs that are associated with MS, and these mainly affect the common theme in all of these is that they affect the function of the immune cells, particularly activated T cells. There are a lot of epigenetic factors that involve miRNA, methylation, and histone modification. These also affect the risk of multiple sclerosis. Now, coming to the basics of the immunopathology, we find that the primary mediators of disease are autoreactive CD4 cells, and they form a central role in the pathogenesis of multiple sclerosis. And if you look at the subtypes, there are the Th1 cells that produce interferon gamma, and they are found in active MS lesions. And Th17 cells, which have a significant role in the pathogenesis and the propagation of lesions in MS, produce interleukin 17. So they play an important role in weakening the blood-brain barrier and promoting neuroinflammation and migration of other cells within the central nervous system. Tregs, which are regulatory T cells, produce interleukin 10 and they're found to be protective. CD8 positive T cells are present in the parenchyma, but and they are present during the phagocytic stage in the lesion stage. So I'll be coming to that a little later. So B cells are found in what is called as ectopic lymphoid follicles, and more and more evidence is emerging that they may be the key players in the initiation of the immunological trigger in multiple sclerosis. A lot of work in multiple sclerosis is actually from the experimental and autoimmune encephalomyelitis. So here, how this is developed, there are both the murine models as well as primate models, and the latest ones involve the marmoset, which is non-human primate. So here, what is happening? They take proteins such as the myelin basic protein or MOG or PLP and inject it peripherally along with an adjuvant and produce an immune response in the animal. And subsequent to this, there's activated T cells from the cervical lymph nodes, crosses the blood-brain barrier and enters the central nervous system. So in this cartoon, you can see that there are activated Th1 cells and Th17 cells. They tend to damage the blood-brain barrier, and Th17 and Th1 cells enter the central nervous system. Also, you see that there are certain other cells called the gamma delta T cells. They also migrate in and they produce interleukin 17 and TNF alpha. And all of these actually cause clonal expansion of T cells within the central nervous system. This in turn causes aggregation of macrophages, activation of the microglia, and there is damage to the myelin by destruction of the oligodendrocytes. And this is how what we understand from this experimental model. But what triggers this autoimmune process is something that is debatable, and we'll come to. Looking at this in a little more detail, so I'll be going through both the adaptive and the innate immune system, and I'll be talking about the important cell types and what is the evidence, the literature evidence that its central role in the pathogenesis of MS. We'll start with the CD4 positive T cells. There's definite evidence that CD4 positive T cells have the central role, mainly because the activated ones migrate and damage the myelin. So what about what are the Th1 cells that migrate? If you look at the surface markers, specifically the ones, a subset of them that express GM-CSF, TNF, and CXCR4 along with VLA4, this subset is the one that has got a high propensity to migrate and damage the CNS. And if you see what are the antibodies, what are the antigens that they target? So even though in MS we've not found any specific antibody that targets the myelin basic protein or MOG, but we find that there are autoreactive T cells. They're targeted against certain myelin antigens. So the three myelin antigens that have been implicated is that these Th1 cells target either the myelin basic protein, the MOG, or the PLP. And emerging, and these three actually Th1 cells propagate damage to the white matter, and they cause white matter lesions. Interestingly, a new called the beta synuclein. So the autoreactive T cells that target beta synuclein, specifically migrate to the gray matter and cause gray matter lesion. And in clinical patients with MS, they have been associated with progression of disease and associated with brain atrophy and gray matter lesions. Going on to the Th17 cells, so they have an important role in the initiation of MS. So they secrete interleukin 17. This in turn weakens the integrity of the blood-brain barrier, and they secrete more pro-inflammatory cells that cause clonal expansion and propagates in the inflammatory response. Treg cells, especially certain kinds of Treg1 cells, are known to reduce disease activity, and indirectly they can be influenced by other things like vitamin D and melatonin have an indirect influence on T regulator cells, and thereby they can reduce the risk of multiple sclerosis. So traditionally, T cells have an alpha beta kind of T cell receptor. An unconventional T cell is the one that contains the gamma delta phenotype. So the gamma delta T cell is slightly different, that it produces interleukin 17 and they can migrate CNS. And there's more and more evidence that this gamma delta T cell migration is an important part of MS pathogenesis. So the other associated cells are the mate cells. Mate cells are called as mucosa-associated invariant T cells. So the common thing here is that they also secrete interleukin 17, and they again migrate and accumulate in the CNS, propagating the inflammatory response in the CNS. Certain kinds of natural killer cells are also associated with developing MS. Coming to monocytes, so once in the acute inflammatory stage of MS, and when there's an acute exacerbation, we find that monocytes accumulate rapidly in this early into the disease, and they are controlled by the production of GM-CSF. And this in turn increases the inflammatory response. So if you look at macrophages are abundant in acute lesions. Their entry, they come and damage the myelin sheath and produce demyelination. So going on to also the other cells that have been involved is the dendritic cells and the antigen presenting cells. The traditional dendritic cells have been not directly involved in the pathogenesis of MS. And there's more and more role of B cells having an important role in antigen presentation as a trigger of multiple sclerosis. So this slide summarizes the complexity of the immune cells and their role in the development of multiple sclerosis. Here you can see that there are certain factors that are anti-inflammatory, certain innate natural killer cells, the T regulatory cells that produce interleukin 10, and the Th2 cells. All of these are more anti-inflammatory. The pro-inflammatory cells, on the other hand, are primarily driven by the Th1 and the Th17 cells. And also there are other cells like the mate cells and the variant, the VNKT cells, all of which propagate inflammatory response within the CNS and cause demyelination. So what happens in the acute during the acute inflammatory response in these in the brain is something that we could be understood. If you look at the stages, the initial is the pre-phagocytic stage. In this, you can see that there are activated microglia, and there is apoptosis of the oligodendrocyte. There is not much demyelination that is seen, and there are very few immune cells that are there. So if there may be soluble factors that may be coming from the peripheral nervous system or from the center of the lesion core, that is actually triggering the inflammation here and causing later the phagocytic stage. Coming to the phagocytic lesion stage, you will find that in this particular stage, there are a lot of myelin-laden macrophages. There is pronounced demyelination as seen in the picture here. There's loss of myelin, and there is limited axonal damage. Then coming to the post-phagocytic phase, now there is the demyelination is complete, and you can see areas where there's remyelination. There are a lot of peripheral immune cells that are abundant, and there's a lot of perivascular cuffing that is seen. So in a subset of patients, if the lesion the inflammation doesn't get resolved, there is a chronic active lesion that continues. There's a rim of active microglia and macrophages with a slowly expanding, demyelinating front. So another thing that happens, and there's a lot of emphasis on it now, is the formation of ectopic lymphoid follicles. So initially in the acute lesion stage, there is opening of the blood-brain barrier, and that's how there's migration of all this, the immune cells from the periphery to the center. But as the inflammation settles down, the blood-brain barrier, when the multiple sclerosis goes on to become a progressive, either a secondary progressive or in a primary progressive disease, you find that there is a compartmentalized inflammation. So whatever the cellular debris that is created by the first damage sets off a chronic inflammation within the central nervous system. And there are ectopic lymphoid follicles. They're called as ectopic lymphoid follicles because they look like a lymphoid follicle that is seen like in a lymphoid follicle. They have a germinal center. They're present of germinal dendritic cells. There are also follicular T helper cells are there, and they are maintained by the Th17 cells. And this in turn is seen as a driver of chronic inflammation. And this chronic inflammation seems to be compartmentalized with an intact blood-brain barrier and seems to propagate, contributing to progressive disease. So as we've seen that multiple sclerosis, the immunobiology is quite complex. Putting it all together, I would try to kind of compile it as a simple thing for us as a take-home message. Multiple sclerosis has certain risk factors. There's a strong 30% genetic predisposition. Certain HLA class molecules are associated with increasing the genetic risk. There are certain viruses like EBV that increases the odds of developing multiple sclerosis and may have an important causal role. There are also environmental risk factors, including diet and gut microbiota. What does this do is that there is, in a patient with a genetic predisposition, an infection or some other environmental trigger may activate the antigen-presenting cells. And what the antigen-presenting cell is of a lot of research in multiple sclerosis, there's more and more evidence to say that B cells may be implicated as a main driver of triggering the inflammation in multiple sclerosis. A lot of the evidence is from the fact that B cell depletion therapy is one of the most successful therapies in multiple sclerosis, despite multiple targets, multiple pathways being targeted in the T cell pathway. Only B cell therapy has found to have a greater response than all the others. So as this, the antigen presenting cell could be other things, but the current hypothesis is that the B cells may play an important role. Once the antigen presenting cells present the antigens to the T helper cells, there's an inflammatory response that is set off peripherally. The ones that are predominantly involved are the T cells, Th1 cells and the Th17 cells are the main helper cells, where the CD8 cells causes cellular damage. So what happens here is the Th17 cells secrete interleukin 17, 21, and 23. This weakens the blood-brain barrier, and there is migration of Th17 cells within the nervous system. This also causes the other cells to migrate. Certain other cells that are implicated are the Th1 cells also migrate within, and also the gamma delta T cells. They in turn secrete interleukin 17, IL-21, setting off an inflammatory cascade, activating microglia, and which again secrete interferon gamma and GNCSF. This attracts other cells, and there is clonal expansion of the T helper cells within the lesion. You'll find that T helper cells increase. There's also CD8 positive killer T cells, and there's migration of peripheral leukocytes, including macrophages that come and damage the myelin. As this is what happens in an acute lesion. And as the inflammatory response resolves, there is remyelination and there is closure of the blood-brain barrier. And if the disease does progress, it becomes a chronic active lesion. There is compartmentalization of the inflammation. And you find that there are ectopic lymphoid follicles that are formed. These are driven by the Th17 cells, It is seen subpially along the meninges or perivascularly. There are dendritic follicular cells, there are follicular T cells, and there's both T and B cells that are present there, and they contribute to chronic lesion and progressive disease. Yeah, and that brings me to the end, and I'm happy to take questions.
Thank you, Dr. Prabhakar, for giving a nice descriptive and way of what happens in multiple sclerosis. Basically, we need to know when we think of giving the medications where these pathways are targeted and how to bring about the newer medications. All these knowledge will help us, especially when we are trying to understand the cortical form of MS as to why these lymphoid follicles have come into picture in cortical MS. Thanks a lot, Dr. Prabhakar. Do we have questions from the audience? I don't see anything. Dr. Rohit, would you want to ask something?
Dr. Prabhakar, sometimes in the clinic, there is always some, we always land up with patients which are not very distinctive and where there is a bit of an overlap. Do you think that considering the MS biology and previous talks that we heard regarding some of the complement level, the complement markers, could there be some additional tools that could help us differentiating these patients in the clinic? Do you think there's a role of, let's say, IL-6 or others, which could add up to our, ability to discriminate patients where there is somewhat lack of clarity?
A lot of the clinical problems would be based on history, clinical phenotype, neuroimaging, and also availability of a lot of these biomarkers. So as in more and more biomarkers become more widely available, and we will be able to use it more. Like for example, looking at the immunophenotyping of the cells from the CSF and peripheral biomarkers, including other biomarkers like neurofilament light chain, and a lot of those will actually give us a clue to kind of differentiate in difficult patients.
Thank you. There's another question. Does the treatment differ from cortical forms of MS versus non-cortical, which is, of course, the imaging part of the whole story? So any suggestions for that?
As of now, the main difference would be between relapsing remitting and progressive types. There are the cortical lesions by traditional MRI methods are not clearly visualized. It's often seen as just brain volume atrophy. So the treatment would be primarily based on whether it's a progressive MS versus relapsing.
Yes.
To just add few things to this cortical MS, this is basically a newer phenotype which has come up. The severity of the illness will be different and the MRI features will be different. I think more research has to come to see whether the different form of medications are going to be helpful.
I think, Netra, there are no more questions, and if there are no more comments, you can close the session and announce the next as well.
Yes. Thanks to everybody. Thanks to all the speakers, Dr. Manjunath, Dr. Kamakshi, Dr. Prabhakar. All of you have been part of this inaugural IN Autoimmune Subsection webinar, which is going to be there every month, twice on alternate Saturdays, except for few times it may be on Fridays, depending on the availability of the times of the speakers. So it has been nice to have all of you here who have set the scene about the basics of neuroimmunology, so that when we understand how it has started, it is more important to understand based on all this, on how we can correlate with the clinical features and MRI. And I would like to tell that the next session is going to be on 5th of July. This is a Friday, not a Saturday. We'll be coming forth. Yeah, thanks, Asmita, for putting up the flyer. So this is going to be a quiz which is going to be held shortly. What are going to be the rules and all will be circulated. So I encourage most of you people to please be part of this. This is just going to be level 1 and the final quiz is going to be held at INCon in Vizag. So welcome all of you and I please ask all your residents and others to participate in this quiz. And once again, I thank Dr. Rohit, who is the chairperson of the IN autoimmune section, who has been helpful in starting this inaugural session. Thanks to Dr. Debashish, Dr. U. Meenakshi Sundaram, who are our IAN members who have been literally pushing us to start this autoimmune section. Finally, the digital team, Ms. Asmita, Mansi, Bhavesh, who all have been instrumental in bringing out this digital platform today. Finally, thanks to all the panelists and attendees. Without all of you, it wouldn't have been possible to go through all this. Thanks a lot, everyone. Thank you.
Thank you.
We can close.